Hi everybody, I'm Laurie Cadden, and we are here for the Lackawanna County Medical Society's Public Health Education Series, and it is the 11th one, believe it or not. And the good news is we have one more to make it 12, and then 12 more, yay! We're all excited about this because we believe that what we bring to you, to the viewing public, is wonderful information that these doctors who have expertise in many areas, and other people, because they're not always doctors here, but just to give you some information about your health, make it available to you, make you feel a little bit more comfortable if you have to go to the doctors or anywhere else, and be able to go armed with a little more ammunition. So we're here today again for the 11th show, and we are here talking about advanced women's health technologies, and joining me to talk a little bit about some really interesting, a surgery that's available that's really interesting, and both doctors have expertise in that. And I think it's going to be very interesting for you to see. Maybe you've experienced it, maybe you're hearing about it, and it's a decision you want to make. These docs are going to be able to give you a little more information about your decisions and whether it's right for you, and as you will tell them, if it's, you'll say, hey, this is good or this isn't. So we'll figure that out as we go ahead. So joining me is Dr. Raymond DeCesar and Dr. Gary Reedy, they are both from Physicians Health Alliance Mount Pleasant. What's Mount Pleasant?
It's the name of the building.
I know, where is it? It's the new facility, right?
Yes.
Right. And how do you like it over there?
We do.
Very nice.
Yeah, you can't help but see it when you're going up Linden or down through the expressway. It's pretty neat over there.
Right next to the expressway.
So is it easy to get there for you guys?
Very accessible.
Okay, so it's a good place. So just so you know, that's where it is. It's located sort of above Scranton High School, over a little off of Linden Street, right? That's where the entrance is?
Mm-hmm.
Directly opposite Redner's Food Market.
Yeah, there you go. So you can get everything done and scoot on the highway and get out. So we're here because, as I said earlier, there's a wonderful surgery called Da Vinci surgery. Both of you have expertise in this surgery. So could we tell everybody out there, what is Da Vinci surgery? Either one can answer. It's fine. Okay, let's flip.
Da Vinci's it's a robotic platform that's used to perform minimally invasive surgery, and you can use it for various procedures in a lot of different fields, but in our field we most commonly use it for pelvic conditions like a hysterectomy or a pelvic support procedure. Some of the oncologists will even use it for more extensive cancer surgeries. But instead of a traditional instrument where the surgeon just holds the instrument, the robotic device holds the instrument, the surgeon controls the robot, and it adds some other aspects of the surgery.
That's really neat. Now, when you do that, does it sort of feel like, the Jetsons or some kind of funky, here we've made it, now robots are doing some of the work, and obviously you need the human to do it. But what does it feel like when you're doing, when you first, obviously you have to become an expert or get expertise in this to do this type of surgery and use this equipment. But when you first started doing it, I want to hear from both of you. How did you feel when you said, oh man, now I'm working with a robot, it's not Rosie, who is it? So how did you feel, Dr. Reedy, when that happened? Because you've been doing it for how long now?
Almost 4 years.
Okay, so what was that like?
Well, you have to go through an extensive training program to do it, and you begin to feel like you're sort of in control of something distant from where you are, which is kind of fascinating to me, because you actually do not sit or operate on the patient directly. You sit away from them when you do it. And it allows you to look through a three-dimensional type of camera with instruments that are smaller than your finger and rotate more than your wrist does, and do procedures in ways that are phenomenal to me. So it's really pretty neat to be able to control that. And the thing is, you control it. The robot doesn't do anything except keep the instruments from bouncing around too much, and it reacts as you react. So much like you see the chemists in the lab with the robotic arms that are turning the beakers, that's kind of how this works. So there's no intelligence in the classic sense of it telling you what to do, but it does the motions that you do, except in a much smaller and more controlled environment.
Okay, and so what did you feel, Doctor, when you the first time? Like, did it feel weird or kind of neat, like Star Wars or something? I mean, it's funky.
The company that actually manufactures the equipment is called Intuitive, And it actually struck me that it to me, seemed a bit intuitive, actually, when I used it. You know, I had been very comfortable with traditional laparoscopic surgery, where you're physically moving the instruments that are on sticks. But when I used this, it seemed like it used more of your natural movements. You know, you would look at something and you move your hands around like this, and the instrument does that same thing. So, you know, they're wristed, you have dexterity, but as Gary said, you know, it can exaggerate like you can only turn your wrist that far. It can, you know, go around very far. So it's what you could do with your hand, but a little more and with a lot finer detail. And you know, another very striking to me right off the bat aspect of it was the magnification and the depth perception that you have with it. You have binocular vision, which gives you depth perception, unlike a traditional scope where you only have one camera. The traditional laparoscopic camera would be a 4-power magnification, 4 times larger than life. This is 10 power. So, you know, I mean, those things really stood out to me early on when I used it, that, you know, it seemed like natural movements coupled with almost superhuman abilities that, you know, you could see things you couldn't normally see. You could manipulate things you couldn't normally manipulate. So, you know, right away it seemed like, boy, this could be useful. You could see where you could do something with this.
So you've been, how many years have you been practicing with it?
This is my 2nd or 3rd year.
I hate to use the word practice here, but
No,
I mean, you know how I mean
yeah.
it.
Yeah, I had been, I think I was 6 to 10 months behind Gary, somewhere in there, yeah.
And where do you go when you get this surgery? Is it yearly, or excuse me, the education? How and the hands-on? How often do you have to do that? And you become certified in it? Okay.
The company certifies you. They require you to do some basically skills tests with the dummy machine on dummy instruments. There's an animal lab. There are observations of other doctors that do it. You have to go through a fairly extensive process.
Training program.
And there's online stuff you have to do as well.
And then you're supervised.
And then you have, yes, the first 3 cases you do, or 2, you have to be supervised by a skilled Da Vinci surgeon.
So they would come here
here.
to when you're doing doing this surgery. Wow. And was that more nerve-wracking than anything else? Because now we know how many, you know, each of you said about 17 years, you said about 27, you're practicing. You're used to just doing this. Was that a little nerve-wracking for you to feel like maybe a student again?
It's a little nerve-wracking. Fortunately, the preceptors that I had were people that I knew, so it made it a little bit easier.
Okay.
But, you know, they have the ability to actually take their finger on a screen and circle things to show you what they want you to do. And so it's a little unnerving when you see coming in your visual field these little circles being drawn to kind of suggest where you might want to go next when you're first learning to do it. But it makes it a lot more congenial to do it that way, and then you feel as if you're a lot more confident by the time you start doing it on your own.
Well, it amazes me that when to even think about robotic stuff anyway, but when you are doing this, does it then take is it a lot of this use because it's less time in anesthesia, or does it require a little more time because now there's manipulation from another into the?
It honestly depends on the case that you have. I mean, the more complex the case, the longer it takes, but the recovery is faster. 95% of my patients are home that afternoon, and probably the other 5, only 2 have stayed beyond one night. So I mean, it's a very rapid recovery. They're back to work in 2 to 3 weeks. With actually minimal pain, which has surprised me.
And how about blood? Blood loss low too?
Oh, terribly low. Most of my cases, I don't know about Ray's, but most of mine are less than 50 cc's.
Wow.
Very minimal.
I mean, you're looking at an artery that's really a whole lot smaller than my finger, but it looks about that big when you're looking at it. So when you can,
because of the magnification.
Because of the magnification.
Yeah.
The other advantage you have is the robot is trained to take the shake out of your hands. So if you have any tendency to do that, so it keeps things steady. The camera stays steady. It doesn't bounce around. So you're actually focused on everything that you're doing. much more efficient in that sense.
So now take me through a patient coming to see you who, let's use, needs a hysterectomy. Let's just use that because most people understand what that means. There's words here I don't know what they mean, and maybe we could talk after this about other something that you may be diagnosed with or some surgery that has to be done, and these are things that, because I don't know what they are. So, but as far as someone who's you feel, okay, we need to have, you need a hysterectomy. And why they call it a hysterectomy when it's for women, I'll never know. I know it's HY, but it just drives me crazy. So tell me what happens when you have that discussion with the patient. Is it their decision? Is it your decision? How, and I know it's going to differ, but in general, what would a conversation like that be?
Well, it's always the patient's decision. I mean, usually they come to you seeking help for a problem that's led them to your office to begin with. And, you know, surgery is typically a last resort, not a first resort. You know, I mean, you can always do a surgery. It's hard to take surgery away. So you'd like to be fairly certain you made the right choice before you do it. And it's a large step, even if it is minimally invasive. It's still a large surgery when you're talking about removing an organ from someone's body. I mean, and having a recovery. And so, you know, typically they would come in, for instance, one of the more common reasons for a hysterectomy is some kind of abnormal bleeding. Well, there could be a lot of causes of that, and usually you'd evaluate those causes beforehand, and you'd rule out the bad reasons, like cancers. I mean, you'd hate to do a surgery and then find later there was a cancer. You can never eliminate that possibility, you know, beforehand, because how do you ever replace the answer you get from giving them the whole uterus to look at, you know, at pathology? But you try to hedge your bets a little bit and make sure you're not surprised. So, you know, usually there'd be an initial evaluation or even a few visits coming up to that surgery that you and the patient would kind of come to the conclusion that that's what they needed. And then, you know, there are a few routes of doing a hysterectomy, as the example of what we're talking about. So then among your decisions would also be that this was the best route for them, that they would recover the fastest. This was, you know, that you could give them the best outcome, basically.
Is that what usually tips it over to that? Is that when you say to them it can be traditional surgery, or can a hysterectomy be done any other way than, how other ways can that be done?
Well,
Traditional surgery, right?
You know, before, say, 20 to 30 years ago, when we didn't have this technology, all of the hysterectomies really were done either with an open incision, that traditional surgery you think of, or a vaginal hysterectomy, which was a unique thing for gynecologists, that you would actually remove the uterus without an abdominal incision through the vagina from below. And it was a lot of art involved in those surgeries. But you know, there's a fast recovery from a vaginal hysterectomy without an abdominal incision. Not every surgery is easily approached that way. As you can picture, there is a lot of room to see or navigate there. So, you know, anybody who couldn't have a safe surgery that way would have an abdominal hysterectomy, and that would usually be the better part of the week in the hospital or in some phase of recovering. You know, just your activities of daily living, basically.
Because it's cutting the stomach muscle and stuff, right? So it's hard to, the recovery's longer.
If you did nothing but make an incision on their belly, that would take them out of commission, you know, and sew it back up. So, you know, then we got into laparoscopic surgeries where we could have smaller ports, typically 1 centimeter, and with a few of those ports, you could do these same surgeries, and the recovery was dramatically faster. And you know, we've kind of touched on a few of the controversial points about robotic surgery versus the other methods, in that you know, there's always argument back and forth. You know, is it cost effective? Is it time effective? Is it necessary? You know, to have a robotic device to do these surgeries?
But you guys would say it is, right?
Yeah, we and a lot of docs, I think, in a rapidly increasing number across the country, really feel that, yes, there is an advantage. And I think I'd say that, you more consistently get the better end result for your patient.
Absolutely.
It's there are plenty of cases that would go well with the other methods or with a laparoscopic procedure. But this is that more advanced type of laparoscopic procedure that you're more likely to get the better result. You're more likely to be able to do things exactly how you would want to be, rather than a compromise. So that's where we feel there's an advantage.
Well, I think the advantage that I see is that I can do basically the same procedure robotically that I could do open, because I have the same ability, if not a little more, than just strict laparoscopically. The
Okay.
instruments in laparoscope are pretty much rigid, they don't move. These are wristed, so they're pretty much like your hands inside without having to have your hands inside.
Okay.
It also works well on people who are of different body habituses. Sometimes you can work better by inflating their abdomen as opposed to cutting through it. You can see what you're doing better. They recover much faster. The decrease in infection rate is phenomenal. And they're back on their feet and back to work quickly.
So then, when I was saying that pushes them over, then maybe because of the recovery time, how quickly they stay in the hospital, and you say, here's the options you have with this. Do you find more and more women are feeling a little more comfortable now with this procedure, and then we'll say to you later, oh, I'm so thankful we did that?
Well, I have many patients that are referred to me because that's what they want.
Okay.
They want a minimally invasive procedure that gets them back to their normal lifestyle quicker. I've had a few people where we've had some discussions, and after they have made the decision and then had the surgery, are amazed at how much better they're doing than they thought they would do. You know, and as a result, that word of mouth spreads, and that makes it, you know, much easier for us to quote, stay in business, unquote.
Yeah.
But I do find that we're also doing procedures I might not have tried laparoscopically because
That
of
you
the
can now do.
complexity of the potential complexity of the problem.
Would you just tell, as I said earlier, what other type of procedures can be done that are gynecologic in nature that can now be done in this with the Da Vinci?
Well, you can do pelvic support procedures, as I alluded to. For instance, a lot of ladies who've had a hysterectomy in years past have laxity of that area, that things will start falling down. And it's a common complaint that a bladder will be leaky, or things just don't feel as supported as they used to. And there are a lot of approaches we can take to pull those ligaments back together. There are some procedures where they use meshes also. Those have been more controversial, but in some ladies, that's, you know, you weigh a risk and a benefit with anything. So, you know, if you're suffering greatly and you have a low risk effective procedure, well, that might be the option for you. Some ladies want to retain their uterus and they're looking for fertility, but they have fibroids, which are a benign lump in the wall of the uterus. You can remove those with a laparoscope, robotic laparoscope, or open, any of those techniques. But again, with this equipment, you have more dexterity, better visualization. You can get the type of result you want a little more readily, you know, as the surgeon trying to give that to the patient. So again, that's an area that this has been useful. You can picture where, with endometriosis, where you're looking for little implants around the pelvis. That's when the endometrial type cells from inside of the uterus spill into the pelvis and cause scarring and pain. If you have better visualization, you can see it better. You know, you have now 10 power magnification. So again, this might be an area where we feel like it's beneficial to approach it with a robotic approach. So those are some other areas that you might use the procedure.
So then this is commonly then used, if it's for fibroids or something else, so all age groups of women are going to need some type of surgery due to some of these type of things. It's not just older. You think of hysterectomies, women who are a little bit, you know, more mature, they may need that. But really, for those type of things, that can happen at any age, especially
That's right.
endometriosis,
Sure.
right?
Well, endometriosis can be done on teenagers.
Right.
It can be done at any age. And as he said, the visualization is better. You can actually dissect out the endometrial implant below what you see with your eye, because the magnification lets you see it. And there's a lot of practitioners that are doing that now that have remarkable results with pain relief,
Yeah.
which is phenomenal.
It's amazing. Again, I just think to have have this and to have it available here is a good thing.
We're lucky.
And we are, and that doctors know how to do it, and you're right here. But then, what are the scars then? Are they similar, or what does the body look like afterwards? Similar then to if you'd have laparoscopic surgery?
It would look very much like the gallbladder surgeries, the laparoscopic surgeries that we do. You generally have between 4 and 5 little incisions.
Okay.
Or less,
depending on the situation. The specimens are generally delivered vaginally, so you don't have to worry about any big scars being made to remove them. There are exceptions to those rules, but for the most part, that's how it's done. And what I find also fascinating is Da Vinci is set up such that the instruments that we place are done physically so that they don't pull the skin very much. So the amount of pain from the incision sites is almost zero. And the biggest complaint that I get, I'd say probably he gets too, is the shoulder and the chest pain from the gas that's left in the abdomen for the first day or so after. That's probably the biggest complaint I ever have.
Really?
And that's, well, with any scope procedure, you have to somehow lift the belly
Inflate,
wall
yeah.
off of the organs underneath. So, we use carbon dioxide gas. When the patient stands back up, sometimes that migrates up under the diaphragm. It's
Causes
trapped in
pain
between
then.
the bowels a bit. We try to get all of it out as we end the case, but inevitably some is there, and that's a
And
common,
that
that's what
seems
he's
to be the
referring to.
complaint
So
that
when
I
they
have.
tell you they feel pain in their shoulder, or that you know
That's a
that
referred
that's
pain
we
point
tell
under the
them-
diaphragm.
We tell them
Okay.
ahead of time to expect that, because they often do. Sometimes they don't have it
Usually
at all.
the first day.
But that's the complaint that I get. I don't get other complaints. As a matter of fact, people are amazed at how minimally uncomfortable they are.
And as far as for someone's insurance, is it readily paid? I mean, is that part of the tricky, sticky thing of this surgery?
It depends on how you phrase it.
Okay.
I think insurance is the tricky, sticky part of a lot of things in medicine these days. It's a nationwide challenge, and it's that could be a whole nother show,
Should we-
probably.
We should, as a matter of fact,
We
that
could talk
should
a
be
long
one
time
of
about
these-
insurance and medicine.
I
and-
know.
and,
But you know what, though? It's wonderful. It's good that it's here. It's good that you're able to do it. And what other, so that I didn't miss anything, is there anything crucial to this show that you would want the viewers to know that we didn't cover? Either one of you. And as far as, I would assume it's always best when you're with your doctor to make sure you know all of your options and what's available, which you just said that's what you do. And then for you to make your decision along with your doctor that this is the best procedure.
Yeah, I think, surgery, as I said, is a very large decision. It's a life-changing event. You'd like it to be a life-changing event for the better. You always expect that there's going to be some investment of time out of work and recovery and pain and, that trial period. But you'd like to think that on the other side, you're going to feel like there was a reason for that and you benefited, and in the long run, you feel better from it, or you address something concerning that you can go on with your life more at ease. So I think that's are we saying that, boy, everybody needs a robotic surgery? No. But if you do come into that situation where you need a procedure, that might be a great option for you. That would make it a little less investment or impact, and maybe a little faster to that other part that you'd like to get to, the result you'd like to have out of it.
And what about you, Dr. Reedy?
I pretty much would echo what he has to say. I just think it's important that you spend the time with the patient, both in terms of the alternative options that you have, but also the potential complications and risks to the procedures, as well as the various recovery times. And a lot of the patients, these are still somewhat elective procedures for them, so they come to that decision on their own most of the time. It's just a matter of trying to help them figure out what the appropriate course would be. I mean, there are just some cases that probably aren't very good for robotics. But for the most part, I think you can do most everything that way today that we have been doing open in the past. So it's just a matter of talking to them and letting them sort of make their own decision, because ultimately it's their decision.
Love it. I think it's great. So keep it up, keep going. And as
Keep
I
trying.
said, it's always a good thing, because not only are both of these guys intelligent and well-versed in the Da Vinci surgery, but they're good looking too. It always helps to be well-rounded. You know what I mean, guys? What do you think? Look at, now they're shy. Oh, they're not going to say
whatever you
anything
say.
about that.
Now we're bright red.
There you go. Well, thank you for being part of this today. We hope that you've learned a little bit more about what your options are if you do need surgery of a gynecologic nature, as both are gynecologists. So it's very important to understand what your options are and talk to your doctor about it. So we'd like to thank you again for all of your candid information. Thank you.
Thank you for having us.
You're welcome. Next up, number 12 will be, wow, 12, I can't believe it, stroke prevention with Dr. Seth Jones. So he practices in Scranton Neurological Associates and serves as the medical director of the Stroke Center at Regional Hospital of Scranton. So we'll look forward to meeting Dr. Jones. I don't know him. I love it because I get to meet all you guys too. I love it.
It's a good man.
It's, well, I heard he is, so we'll meet him. We'll see. We'll see. We'll see what happens. I'm sure he'll be fine.
I'm
What
sure
do you
it'll
think?
be terrific.
Make sure when you see him, say, it's easy.
You gave him a
It's
plug.
really easy, Seth. Okay? Okay, so we'd like to thank you for watching once again. Again, stay tuned for number 12. This is number 11 coming to a close, and it is the Lackawanna County Medical Society's Public Health Education Series. And I want to thank you so much for listening. It is brought to you in part by CHS. And thank you for ECTV for airing and for all of the work that doctors do in our area to make it a healthier area to live in. So I will see you next month. I'm Laurie Cadden. Have a great week.